Good morning and welcome. Thank you for joining me here today. My name is Jordan Pruktin. I'm one of the cardiac electrophysiologists at the University of Washington. And I'm going to just do a little bit of update on pacemakers and ICDs, leaded and unleaded, which is supposed to be a little bit of a pun on leads. We'll see if you find that funny or not. I have no disclosures. Our learning objectives for today is to describe the basics of how cardiac devices work, understand who may undergo an MRI with a pacemaker or ICD, and recognize who are good candidates for leadless pacers and subcutaneous ICDs, a couple of the newer types of devices. So how devices work. So hopefully you guys have a basic understanding of this, but just to really hit some of the basics. So pacemakers treat slow heart rates. The way that pacemakers work is you have a generator or a can. That's the part up here that usually goes in the left pectoral area, but can also go in the right pectoral area. And the generator has the battery, it has a circuitry, and then it has a connector or a header block up here. Then there's the lead or the wire that goes into the heart, and you can either have 1, 2, or 3 leads in the heart. The lead has a tip electrode and a ring electrode, and what the pacemaker does is give electrical energy that goes down the lead to the tip electrode, and then there's a vector between the tip and the ring, a cathode and an anode, for that electrical signal to then stimulate the heart muscle. There's a couple different types of leads. There's active fixation leads or passive fixation leads. So active fixation leads have a screw on the end of them, and either you can rotate the whole screw, or there can be just a part of the lead that when you implant the device that you're able to turn where it can extend and retract the screw. So here it's extended, and then you can retract it back if you need to reposition it. And the benefit of an active fixation lead is that you're able to place that lead anywhere in the heart chamber because there's a screw that you can attach that lead into. Passive fixation leads have tines on the end of them. You can see pictures of different types of the leads here with these tines. And what happens is that those tines get lodged in the trabecula of the right ventricle or the right atrium if you're going to put them in the atrium. And it allows the lead to stay fixed in place without pulling backwards because those tines provide a active force to prevent the lead from being pulled backwards. The benefit to a passive fixation lead is that oftentimes you'll have a little bit better threshold, so that means less energy needed for them, but the downside to them is that they can really only be placed in the apex. ICDs, implantable cardioverter defibrillators or implantable cardiac defibrillators, they treat fast heart rates. The way this device works is that you have your generator, and the difference between this generator or can compared to a pacemaker is it has to have both a different battery but also capacitors. So the energy comes from the battery and it's stored on the capacitor, and that allows the device to give a shock to get someone out of ventricular fibrillation or ventricular tachycardia. Typically nowadays, most of the leads that are put in for defibrillators have one coil on them in the right ventricle, like you can see here. Occasionally we might put leads in, and especially some of the older leads will have a second coil up in the SVC. There's not as much of a benefit we found anymore to have the leads with a coil in the SVC, and if the lead ever were to need to be taken out for some reason, like infection, it's tougher to take out a lead that has a second coil here in the SVC. So most of the leads that are being put in nowadays have a single coil in the right ventricle. And when someone needs a shock, the vector is between the coil in the heart and the generator, typically again in the left chest area, but it can be in the right chest area. All right, so to talk about some of the newer issues, the newer features that the world of pacing and defibrillators have gone into in the last few years. So number one, which you guys probably are aware of, are biventricular devices. So these are most commonly used for people whose ejection fractions are less than 35%, who have some element of heart failure, New York Heart Association class 2, 3, 4, and have a left bundle branch block. Though we will use these in people sometimes who also have a right bundle branch block or have complete heart block, or who are needing frequent pacing from the right ventricle. So with this, if you imagine that someone has a left bundle branch block, the picture that you're seeing here is supposed to represent the electrical timing of the heart. So if someone has a left bundle branch block, what you'll see is that the right ventricle electrically is activated first, And then the signal makes its way through the myocardium instead of through the His-Purkinje system to activate the lateral wall of the left ventricle very late. So if this is the left ventricle here, you're going to get septal depolarization first before you get lateral wall depolarization. And that can lead to mechanical dyssynchrony, so that the septum moves and then the lateral wall, and they sort of go like that. But if there is a way to pace the lateral wall at the same time, you could make there be more synchronous activation of the left ventricle and have all the walls move together. So that led to the concept of biventricular pacing, where a lead is placed into the coronary sinus, and the coronary sinus empties into the right atrium through a little hole right here, the ostium. And then the main body of the coronary sinus runs posterior to the mitral valve. And then there are some branches that will go off onto the lateral wall, hopefully, of the left ventricle, or the posterior wall, or even the anterior wall. And if you pace the heart on that lateral wall and at that RV apex, which is activating the septum, at the same time, you can have more improved activation and mechanical synchrony of the left ventricle. And studies have shown that people who get this device placed who meet these criteria can have an improvement in ejection fraction, an improvement in quality of life, an improvement in exercise capacity, and an improvement in mortality. One of the new changes with this in the last couple of years is that traditionally these devices, this left ventricular lead, has had two electrical poles on them, what are called bipolar leads. One pole here and one pole here. And you can see on this lateral chest x-ray, it's one pole here and one pole here. The newer devices, and this may not come through super well, but the newer devices, the newer leads have 4 poles on them. So this one is 1, 2, 3, 4. On the lateral view, you can see 1, 2, 3, 4. So the benefit of these newer devices, or the newer leads, has to do with, in a lot of ways, reducing complications of the device. So number one, what you want to do, if you can, is try and pace the heart in as basal a location, in as backwards towards the mitral valve that you can. And with leads that only have 2 poles on them, if the lead goes in very far towards the apex, you don't have a pole far enough back to be able to pace the heart. And so this is a way to improve the success of the device, to be able to pace more in one of these basal locations. One of the other issues is that the left phrenic nerve can run right by the heart where these leads are located, and you can pace the diaphragm unintentionally by pacing the phrenic nerve. It's called diaphragm stimulation. So if you find a set of poles that you're not happy with because they're pacing the diaphragm, so for instance, if you're pacing from this pole to this pole, you may find that if you pace from here to here, there's less of an issue with that and less complication associated with the diaphragm stimulation. Another option with these devices is that you can improve the battery life of them. So you can search among these poles of the ones that are in a location that you're happy with and find the one that has the least amount of energy that it takes to pace the heart so that the device is able to last as long as you can. One of the other new concepts, really in the last year or so, is the idea of physiologic pacing and pacing of the His bundle. So we were just talking about physiologic pacing with biventricular pacing, and with that you get to you're pacing the right and left bundles at the same time. One of the ideas may be that if you can pace the His bundle itself, so if you remember from your cardiac anatomy, you have your AV node, your His bundle, and then your right and left bundle. And a lot of the blocks that we think, like right bundle branch block or left bundle branch block, don't actually happen in the right or left bundle, but are actually happening in the His bundle in some preferential fibers that go towards the right or left bundle. So the idea is that if you pace the His bundle, you may be able to maintain that active synchronous conduction still going down the right and left bundles by trying to pace that specific location instead of pacing in the RV apex. So here's an example. So this is trying to show that this patient here on this left figure has a right bundle branch block, but that right bundle branch block is occurring in the His bundle. And if you look at this EKG up here, and if we just look at V1, you can see that there's this RS, R prime, which is what we see with the right bundle branch block, and that the QRS measures 170 milliseconds in duration. When you put a pacing catheter right at the His bundle, and if you pace at a little bit higher energy, what you can see is that you're able to capture and pace this distal right bundle and still have the signal go through. And if you look at the QRS complex, now, number one, that QRS complex is 100 milliseconds, and it's narrowed back up again with a normal morphology. If you decrease the amount of energy at this location, you're just pacing this left bundle, and now you see this right bundle branch block pattern come back again on the EKG. So the concept of His bundle pacing is a really exciting one, because this way you can avoid some of that dysynchronous contraction that might occur with RV apical pacing. And I'll show you, this is an example from a patient of mine from a couple weeks ago. And what you can see on this EKG is he has a little bit of an element of sinus bradycardia. So here's a P wave, here's a P wave, here's a P wave, here's a P wave. And it's a little bit under 60 beats a minute. There's also a significant PR interval here. This is almost 600 milliseconds that you see. But you also have AV Wenckebach. So you have this very long PR interval. It's a little bit longer, really long, dropped beat, and then it's a little bit shorter relatively. It's still obviously quite long, but it's shorter compared to this last conducted one. So for this patient, he was actually having some heart rates in the 30s, and he was starting to feel dizzy. And especially in this situation where we felt, because of this very long PR interval, that his level of block was in the AV node, he was very interested in the idea of doing His bundle pacing. And when we placed his device, you can see a couple features here on his EKG. Number one, what you can see is that he's atrially pacing now. So here's a pacing spike, and then a P wave, a pacing spike and a P wave, a pacing spike and a P wave, and so on and so forth. But also you can see on his EKG that there is a pacing spike here for the ventricle, and this is a relatively narrow QRS complex. There is a little bit of this RSR prime, but it's less than 120 milliseconds. So this is really more of an incomplete right bundle branch block. And if you look at the morphology of this and compare it to his pre-EKG, if you look here at that V1, it looks very similar to what you're seeing here. So in this situation, we were able to pace his His bundle. He has a narrow QRS complex, and I think most people would look at this and say, yes, this looks like it's a normal QRS complex, and they'd be very happy with the idea of having physiologic pacing. The chest x-ray location, if you look at these, the EKG of these patients, it's going to look a little bit different. That here's your atrial lead in this patient, which looks like a normal atrial lead position. But the pacing lead for the His bundle is much higher than what you're used to seeing. Typically it would go down by the apex. Here you can see this is really on that, almost on the atrial insertion side of the tricuspid valve. And on a lateral view, you can again see that this pacing lead here is not in the RV apex, but is in a much more proximal area than that. You can also see, if you look closely, that this lead is thinner compared to the other one, and that has to do with some of the delivery tools that we use to get this lead into the proper position. So I think this is actually a very exciting development, and it's technically challenging. It takes extra time to do this, and it can add anywhere from 5 minutes to even an hour to try and find that exact position. I had a patient who I did last week who actually had Mobitz 2 heart block, and you could see with the catheter in that position that he had an atrial signal and then a His signal and then a dropped beat. But we were actually still able to pace him from the His bundle, so that his level of block, it's telling us, is in the His itself. And so we're able to pace him physiologically, and hopefully this will reduce any chances that he might have any pacing-induced LV dysfunction that some people can get over time. MRIs and devices. So there are some new developments in the last few years having to do with MRIs. Some of this you might know, and some of this you may not know. In terms of pacemakers and ICDs, there are now several different types of MRI or conditional devices, or FDA-approved MRI conditional devices. So each of the manufacturers now makes a pacemaker with leads that you're allowed to get an MRI for if the pacemaker is checked right beforehand, the patient undergoes the MRI, and then the device is checked right afterwards. There's actually even now devices where you can pre-program an MRI settings, and that the device is able to tell that the patient has gone into an MRI scanner and can automatically change its settings so that you don't even need to have someone program it ahead of time, or at least not immediately ahead of time, as long as the those settings have been programmed either at the time of implant or at a clinic visit so that the device knows what to do once it enters the MRI environment. There are a couple ICDs that are FDA approved to be MRI conditional that can go in the MRI environment also. Not every manufacturer makes those yet, though. I think one of the things is really the idea of doing MRIs in patients who have the non-approved devices. So we know that MRIs are clinically useful. So here's just an example of someone who got a CAT scan, and if you look at C3 and C4, they look relatively normal, but on MRI, there's this hypodensity, and this was in someone when they read this MRI that was felt to have osteomyelitis and an epidural phlegmon. In this person here, here's a CT scan which shows no abnormalities, but the MRI shows this change here, and this was associated with a stroke. So we know that there are situations where MRIs really are clinically useful and really are a better test, improved compared to a CAT scan, an X-ray, an ultrasound, or PET scan, or some other imaging modality. The classic issues that have to do with MRIs and cardiac devices have to do with things like concerns about device movement. So this is pretty unusual nowadays. The devices are built so there's not much ferromagnetic material in them. So it's really not a big concern at this point. There's the idea of the magnet effect. I'm sure you guys are aware that if you have someone who has a pacemaker and you put a magnet on top of the device, if it's a pacemaker, it will make the patient pace in an asynchronous mode. So they will start pacing at AOO, VOO, DOO, but at some heart rate, regardless of what is happening with the patient's intrinsic cardiac signal. With defibrillators, when you put a magnet on the device, it turns off the shock portion of the device and it has no effect on the pacing. So the concern when you get an MRI, which is a big magnet, is that magnet effect, or that it will trigger a magnet effect. And that is classically what had happened when the devices had a part of it called a reed switch in it, and they've switched now to a Hall sensor, so they're able to not have that be as big an issue. You can also get heating of the device or heating of the leads. So patients may talk about when they get an MRI that they feel the device just a little bit warmer, a half a degree or a degree warmer. It's not really a significant issue. What is a little bit more of an issue in some situations would be heating of the leads. And if you get heating of the leads and that energy is transferred all the way to the myocardium, well, that could be a big deal. You can see decreases in the battery voltage. And the reason that is important is it can reduce the longevity of the device, which obviously is an issue. One of the big issues also would be concerns of oversensing or undersensing. So if that were to happen, you can either have inhibition of pacing, so someone needs pacing and it doesn't happen, or you force pacing. Someone who doesn't need the pacing, but you start to pace them, and you may start to pace them even in situations that are really quite rapid. Another concern would be oversensing with defibrillators, and if you don't make the appropriate settings adjustments, that someone could get shocked by the defibrillator because the device thinks that someone is in ventricular fibrillation. One of the other concerns would be electronic reset of the device. So I think of it as a software reboot back to factory settings. And if you have a reset of a device, it can be quite a big deal. And then artifacts. So this is another issue, would be imaging artifacts, that the quality of the picture may not be at the level we'd like it to be. So there was a large study that was just published a few months ago in the New England Journal, and this was called the MagnaSafe study. And this had 1,500 patients in it from many different centers, 1,000 patients who got pacemakers and 1,000 patients who had pacemakers and 500 patients who had an ICD, who had a clinical indication for an MRI. And for these patients, they looked at what were the outcomes if they got an MRI. And what you can see here in terms of the primary endpoints is that 0 patients died during the MRI exam. Only 1 patient had a generator failure. And if you read this little asterisk, it seems like what happened was that there was an inappropriate programming of the device prior to the MRI, and there was some confusion related to that, and they changed the device, but when they actually looked at it in the end, there was no abnormalities found with it. 0 patients had any lead failure that required immediate lead placement. They only did MRIs in people who were pacemaker dependent with pacemakers, but not defibrillators, and we'll get into that in a minute why. But in this situation, 0 patients had loss of capture. There were 5 patients with a pacemaker and 1 with an ICD that had an observed atrial arrhythmia, like atrial fibrillation. Now, this isn't very surprising. A lot of these patients have other cardiac disease and have atrial arrhythmias, so this is probably within a range that seems normal to me. 0 people, though, had ventricular arrhythmias, and 6 people did have this electrical reset. Now, all 6 of these, they were able to program the device back to the settings that they originally had, but this can sometimes take quite a long time to go through every single setting that the device has to make it back to what the patient was like beforehand. And what they have to do, or what you have to do, is print out all the parameters beforehand so you have a record of it, so that if an electrical reset happens, you can make those changes back again at the end. There can be a not a partial electrical reset, but a full electrical reset. And if that were to happen, which is rare, but that would be one of those things where the generator failure requiring immediate replacement. And again, that didn't happen in this study. In terms of their secondary endpoints, so there were some changes that happened to the device. So there were people who had a battery voltage decrease of 0.04 volts. That may not seem like much, but that might be even several months worth. And there's both what was seen immediately, just after the scan, and also in the long term. And you can see that about 4% of ICD patients had a significant decrease in the battery voltage that may be several months. But if it is felt like it's clinically useful to get that information, many patients, if not most patients, would be willing to give up a few months of battery life to be able to get the answer to another clinical question. There were a few people that had changes in the pacing threshold, and this is significant, again, having to do with battery longevity. If you have to pace with more energy, then the battery is going to last for less time. Some changes in the P waves and R waves, and this has to do with sensing how well the device sees the intrinsic cardiac signal. For R waves, there was none of them that had any significant long-term changes, and very rare was the P wave, which is the atrial lead, having any significant change. And then impedances, and this has to do with, again, this ties into the longevity of the system, and for high voltage impedance, it may get into issues of how well an ICD can shock someone. And there were some changes in this, but I would argue these probably aren't very significant changes in the end. So I think what this study shows us, really a quite large population, is that for many patients who do not have an MRI conditional device, they can still get an MRI done if it's done in a safe environment. So we at the University of Washington have been doing these for about 5 years or so, and this is the way our protocol is, which is developed based on the Johns Hopkins protocol. The group from Johns Hopkins were really the pioneers in terms of doing these MRIs in people who have these devices. So we will do MRI scans of people who have FDA conditional or non-conditional devices, as long as the generator was not implanted prior to 2000. And it's pretty rare nowadays to have someone who has a device that is 17 years old. I just have 1 or 2 patients at this point that I follow who have generators that are that old. The leads can be of any age, it's just the generator itself. Now, one of the criteria is that the patient can't be pacemaker dependent with an ICD. There are some concerns having to do with the ability of the device to continue pacing during the MRI scan or afterwards. So in patients who are pacemaker dependent with an ICD, we won't do an MRI, but you can be pacemaker dependent with a pacemaker. And you can't have any abandoned leads, retained lead fragments, non-transvenous epicardial leads, or floating SVC coils. So essentially, you need to have 1, 2, or 3 leads that all go into the vasculature, so into one of the cephalic, subclavian, axillary veins, that are all screwed into or have a passive fixation lead that are into the heart itself. So abandoned leads are leads that used to function and don't function anymore, and they're left behind. Same thing with any retained lead fragments or parts that are left behind. Non-transvenous epicardial leads. So these are leads that are placed on the heart by a cardiac surgeon, versus a coronary sinus lead, which would be a transvenous epicardial lead. Those are okay. There are concerns of heating, and if the lead is in the epicardial space, that in a non-transvenous epicardial space, there's not the blood flow to cool any heating at the lead tip. And the floating SVC coils, these are actually quite rare nowadays, but these are leads that are just placed in the SVC for ICD shocking. They can't have had the device implanted within the prior 6 weeks. I know some people will do it to 4 weeks. And this just gives a little time to be sure that the leads are all sort of stuck in place in the heart. Our practice at our institution is that we won't do a MRI of the thorax in a patient who has an ICD. The MagnaSafe study excluded the entire thorax. We will do people who we're looking at the thoracic spine, but really if you're trying to do a cardiac MRI, we won't do that at our institution. And part of that just has to do with imaging quality. You need some specific MRI sequences to be able to still see the heart with an ICD. We don't have this issue with pacemakers, so we will do MRIs of the heart in people who have pacemakers. And then there has to be greater than 3 months until elective replacement indicator, or until the time that you have to replace the battery. So if you have someone whose device is nearing the time that has to be replaced, what we don't want to have happen is that that last little bit of juice that's still in the battery, that the MRI scan drains that, and then we make them reach that elective replacement, to reach the elective replacement. So typically what we'll say is that they should either have their device changed out first, or that the MRI scan is delayed in some way for that greater than 3 month window. Our protocol, the way we do it, is that we review the records beforehand to be sure that the patient doesn't have any of those abandoned leads, epicardial leads, etc., and that the generator has been placed within or since the year 2000. And then what we will do is we will consent the patient, and then we will program the device, interrogate it, and program it just prior to the MRI. And then during the MRI scan itself, we have the patient monitored on ECG and pulse oximetry. So they need to be continuously monitored for this. Depending on the situation, if we have someone who is not pacemaker dependent, we may or may not do a blood pressure monitoring. But if we have someone who's pacemaker dependent, or if we have someone who has more significant heart failure and we've had to turn off their biventricular pacing for some reason, then in that situation we would do blood pressure monitoring. And it's sometimes quite difficult. The MRI can cause a lot of artifacts, especially with the ECG. So the purpose for the pulse ox doesn't have really anything to do with looking at the oxygen levels. It's really just another way to look at the pulse when you look at the pleth. And then the patient should be asked for symptoms. So we ask questions of, do they feel any irregular heartbeats? Do they feel any heating at the site? Or do they feel anything else funny? And we have stopped some scans from people who have some abnormal heart rhythms, or if we just can't figure out what's going on. We do the reprogramming immediately after the MRI. And during this time that we've made these programming changes, the patient is on telemetry the entire time to make sure that we're able to monitor them this entire time. And then we do either a in-person or a remote monitor interrogation in 1 to 3 months to be sure that there's been no changes to any of the sensing or the threshold. One of the things to be aware of, though, is that CMS currently does not pay for the MRI unless it is an FDA conditional device. So if your patient needs an MRI, the hospital or whatever organization you have that does your imaging is going to have to eat up the cost of that MRI. And I will say that this is there's currently an open enrollment period for public comments that I think just finished up a couple weeks ago, where the CMS may be changing this policy. And this is also very resource heavy. So if you're going to do this, you need someone who's able to review the chart beforehand, and then you need someone who's able to program the device beforehand, who then does the monitoring of the patient during the scan and then reprograms it afterwards. So that takes several hours of time, and your institution needs to be willing to support that. Let's talk about the subcutaneous ICD. So I'm not sure if you're aware of this device. It's been around for maybe about 4 or 5 years or so at this point. We know about the traditional defibrillators, and traditional ICDs have a generator that goes in the left, or as I said, the right chest area, but more commonly the left chest area, with a lead that goes into one of the veins and then goes through the vasculature and into the right ventricle. The subcutaneous ICD is different. This has a device where the picture has it a little bit high here, but the generator goes in the mid-axillary line at about the 4th or 5th intercostal space. And then the lead stays extrathoracic, so nothing is going inside the heart. It stays outside the rib cage. It's tunneled under the skin along over to the xiphoid process, and then the lead runs typically on the left side of the sternum, though it can be on the sternum or to the right side of the sternum, but typically from the left side of the sternum. And when it shocks, it's shocking between the generator and this coil that's right here, the C, and it shocks across this vector. When it does its sensing, it's either doing it from the tip to the generator, from an electrode down here to the generator, or from the tip to this electrode. And the device is programmed in a way to make it choose which of those vectors it uses. And this, in some ways, is more of thinking about a device like an implantable AED as opposed to a traditional defibrillator. This device is really designed to be able to shock the heart, and that's it. It doesn't do any pacemaking. It only just does about 30 seconds of pacing after a shock if it's needed, but it's not like a traditional defibrillator that has a pacemaker built into it. On a chest x-ray, this is what the device would look like. So the generator here you can see is on the left side of the chest. The lead is tunneled underneath the skin and goes up right here. It's a little bit on the left side of the sternum. On the lateral view, you can see the generator sitting right here, and then the lead, again, is tunneled anteriorly here on top of the sternum. So the people that are really the best candidates for this are people who have lack of vascular access for some reason. So for whatever reason, they've had a history of DVTs, there's stenoses, and there's no way to get into the upper vasculature. Or someone who's has end-stage renal disease. So for this person, they might have a fistula, and you can't put a device in at the same side of the fistula, and you may want to avoid the other side in case they need to use that other side in the future for a fistula. In addition, patients who have end-stage renal disease on hemodialysis have an increased risk of infections. And so for those people, the subcutaneous ICD, which is not in the bloodstream, may be a good option. For younger patients, especially patients who have channelopathies like long QT syndrome, this could be, in my mind, is actually a very good option. The biggest weak point with transvenous ICDs is the lead. And especially people who are younger, especially people who have a normal ejection fraction, especially people who are more active, that lead is going to break at some point. There's no doubt about that. It will fracture at some point. The subcutaneous ICD has a lead that's designed to be more robust. It's not designed in a way that can ever go in the heart because it's so stiff that it would perforate the heart. But to be put underneath the skin and right outside the rib cage, it's really designed to last a long time. There's been only very rare reports of the lead ever breaking at this point. So the expectation is that that lead will last for decades. Of course, we don't have any proof of that, but that's really what we're hoping for and what we're expecting with something like this. I think it's a good option for people with congenital heart disease. So for people who may not have the ability to get into the right ventricle, it could be a good option. I think anyone who has high risk factors for infection, so if you have someone who you're concerned about is going to be more likely to develop endocarditis for whatever reason that may be it IV drug use, be it a prosthetic valve, whatever the reason is, this may be a way to reduce the chances of infection. You can still get a pocket infection with this device, an infection locally at the site, but you really can't get endocarditis from this device because it's not in the bloodstream. But really, I think anyone who needs a single chamber ICD, this really could be considered a device for them. And it's really a patient preference for a lot of people, as long as you don't need pacing. And again, the people who are bad candidates is anybody who needs pacing because this defibrillator can't pace you. So if you have someone who also has sick sinus syndrome, who needs an atrial lead, this is not the right device. If you have someone who needs a biventricular pacing, this wouldn't be the right device. If they have a left bundle branch block, and they have heart failure, really you're going to be looking to do a biventricular transvenous ICD. The device is set to only go down to 170 beats a minute. So if you have someone who's got a slower VT than 170 beats a minute, this wouldn't be the right device for them. That said, people like that, you're going to also be considering doing ablation or doing antiarrhythmic medications. And then again, some people who have VT, ventricular tachycardia, can have anti-tachycardia pacing from a transvenous device. So anti-tachycardia pacing is a way to pace the heart a little bit faster than the VT. And it's a way to terminate some of the ventricular tachycardias without needing to shock the heart. And this device doesn't have that capability. Patients who get this device beforehand need to have screening, and this is just so you're aware that this concept of ECG screening exists ahead of time. You have to put pacemaker leads, the left leg electrode where the device would be, the left arm electrode where one of the sensing electrodes of the lead is, and the right arm electrode where the other sensing electrode of the lead is. And what you do is you have this EKG that's created, and you have these 3 different leads, and then there's this template or this screening tool that looks like this. And what you're looking for is that the EKG, here's just one beat, fits within with the QRS complex and the T wave fits within one of these templates. You might have large T waves, like in this example, where you have your QRS complex that fits nicely here, but that the T wave is too large. And so the concern if you implanted the device in someone like this would be that the device would double count their heartbeat. It would think that this is a second QRS complex. And so if you had 100 beats a minute heart rate, it may think it was 200 and give an inappropriate shock. So somewhere between 85 and 95% of people will pass screening and would be candidates for the subcutaneous ICD. There are some people who wouldn't be because they have large T waves usually, or they might have large QRS complexes, but almost everyone has large T waves. One of the issues is that some patients may have changing T waves. So occasionally for some people, we might have them run on the treadmill and look at their screening on the treadmill also. This is what an implant looks like, and this is what the device looks like. It is bigger than a traditional ICD. This is actually one of the first generation devices. The second generation devices are a little bit smaller. But with this device, again, here is the axilla is up here, and the head is up here, and their legs are down here, and these are my hands, and we're implanting the device here. And this is what it looks like afterwards. So just a couple patients. This is one where you can see the device a little bit more. This was not someone who recognized it or felt it at all. And in this patient, you actually, you can barely even see the bump there compared to on the other side. And you can also see that there is a second very small incision of the xiphoid process that you can see right there. This is just, this was one of the smallest people that I did. So this was a 14-year-old who weighed under 100 pounds. And this was about a 1 week later, you can see, and it does stick out a little bit in him. But this was someone who really, because of congenital heart disease, didn't have the option of going into his vasculature. And then people ask about women, and you can see here with the bra, the device is sitting right here, and it really wasn't causing any significant discomfort. All right, one of the last or other new technologies that I'm going to talk about is leadless pacing. So this, in my mind, really is the future of pacemaking and pacemakers. So there's currently one FDA-approved leadless pacemaker available, and this is the micro device. And you can see the device here relative to the size of a nickel. This is the entire pacemaker. This has the battery, this has the circuitry, this has the electrode at the tip, and it has these tines to keep it in place. So here again, you can see what it looks like. There is a pacing electrode on the very tip here, and then there's a second electrode back here, and then there are these tines, and I'll show you how the device is implanted here in a little bit so you can get a sense of how these tines function. But this is, to me, an amazing new technology. This device is placed from the femoral vein, and it goes into the right ventricle here. And you can see that it's implanted in the right ventricle, and you get a sense here of that these tines are able to be embedded through the myocardial tissue. Now, this is, at the current time, just a single chamber ventricular only pacemaker. They're working on future technologies where one device may be able to sense in the atrium and pace in the ventricle. So if you have someone who doesn't need atrial pacing, for instance, someone with complete heart block, this is probably going to be an option in the future. And then eventually you're going to see two devices, one in the atrium and one in the ventricle. I think we're several years, if not even longer than that, down the road. These devices are really best for someone who has bradycardia and is in permanent or persistent atrial fibrillation. So someone who only needs ventricular pacing. There may be the occasional person who has sinus node dysfunction or has complete heart block and sinus rhythm that you would pace only the ventricle. And for these people, typically these are people who would either infrequently need pacing or they're older, and the idea of AV synchrony isn't quite as big a deal as you are older. Someone who's sedentary and doesn't exercise or move around very much, if there are anatomic issues and you just can't get to the atrium for whatever reason, or if there's felt to be other comorbidities that increase your complication risk. So here's just a video of me implanting one of these devices, and you can see that there's this large sheath that goes into the right ventricle, and as we pull back the sheath, those tines get implanted into the right ventricle, and then we're able to pull this sheath back. So here it is, that sheath is being deployed or pulled backwards, and that these tines are now being embedded in the myocardium. as we're doing this, and then we pull this sheath back. We'll look at this one more time, and you can get a look at here at the tip. As we pull this sheath back, those tines, which are initially straight, curve out and enter into the myocardium. And one of the interesting things is, once we do this, this device is now implanted and would be considered working. Now, one of the things that we do to make sure that we feel like this device is not going to dislodge is you do what's called a pull and hold test or a tug test, and you're looking, of these 4 tines that are here, do 2 of the 4 look like they are embedded in the myocardium? And here I'd say that one of these down below looks like it bends as I'm tugging on it, and then there's another one up top here that looks like it is embedded. As long as there are 2 of 4, the dislodgement rate in the studies have been 0, so you really feel comfortable if there are 2 of 4 implanted. Now here you're going to see, with this one I thought that there was just 1 implanted, so I was not happy about that. And on the right side here, as I was doing my tugging, we actually pulled it loose, and so obviously that's not going to be a good situation. There is a little suture that is attached to the back of this device that goes all the way through the sheath outside of the body. So this tugging is done through this suture, and if we need to recapture this because we're not happy with this, that we're able to with this suture, and we're able to advance the sheath back over again over this device. The main study published in the New England Journal about a year ago showed that the complication rate was about 96% in this, actually it was about 4%, sorry, 96% freedom from major complications. This was not a randomized study, but when you compare it at least to historical controls, this seems to be equal to, if not better than, transvenous devices. So really when I talk about this device with people, I'm trying to talk about what I personally perceive as a lower complication rate compared to transvenous devices, knowing again that we do not have a randomized trial for that. One of the other concerns is longevity. This is a small device, and these devices are much more dependent on the percentage of pacing that you do and the output, or the amount of energy that you have to give to capture the heart. So if you look at this table here, your percentage of pacing is on the top, and your amount of energy that you're using for pacing is on the left side here. And typically we're trying to shoot for that 1 to 2 volt range for pacing, but really we're honestly trying to shoot for more the 1 to 1.5 volts. And if you have someone who's pacing 100% of the time, in this range you're looking at between 8 and 11.8 years. But if you're pacing someone who paces infrequently, you're looking at the projected estimates of 13 to up to even 15 years here. And there are ways to make this longevity more. If you pace someone at a slower heart rate, and if the impedances end up being higher, you might actually be seeing longer life of this device, and that's what it's looking like over time. Now, in patients who've had either autopsies or who've had transplants, they've been able to look at what it looks like here over time. And here's just one example that you can see this device is really buried in this myocardium. And so one of the questions has to do with your ability to get this device out if you need to for some reason. And there is this little mushroom portion here on the back that you can try and use a snare to grab. That can be done to get this device out. But if it's embedded like this, it actually may be difficult, if not impossible, for some people. One of the other questions has to do with, well, what do you do when that 8 to 14 year time frame comes up and the patient needs a new device? And while there are not many people who are in that situation yet, because this is a newer device, what it seems like is that the relative size of the device compared to the RV is pretty small, so you can put multiple devices. And in either cadaver specimens or in animal specimens, they've been shown that it's safe and feasible to put in at least 3 devices in people. Just another example of someone who was 1 year later after the device was implanted, and here it looks like would be a little bit easier, that there's not as much myocardial ingrowth on this portion, that you should be able to reach this portion right here, this mushroom portion on the back, to snare it if it were to need to be snared for some reason, though that the need for that would be infrequent. Currently, Medicare will reimburse the cost of this device. This is a change in the last few months. So for CMS patients, for Medicare patients, you are allowed to implant this device. But for commercial insurers, right now it is not really reimbursed. So for patients who have commercial insurance, this is not an option for them unless they were to pay out of pocket, which is, of course, going to be expensive. This device does cost more than a transvenous device. About two and a half times the cost of a transvenous device. So what I'm about to tell you is a little bit more about the future of devices. This is not FDA approved, the information I'm giving you, so please understand that. So things like doing a sub-Q ICD and a leadless pacemaker, so having the combination. So if you have someone who, for whatever reason, can't get traditional device, it is likely going to be several years in the future that you will be able to do a combo device like this. And one of the advantages of this is that in addition to the subcutaneous ICD, by having this, the leadless pacemaker, you would be able to give anti-tachycardia pacing or bradycardia pacing if needed. There is in development this implantable subcutaneous string defibrillator, so another type of defibrillator similar to the subcutaneous ICD, but a little bit smaller without the large generator. So that's another thing that's currently in development. And then there's this idea of doing epicardial pacing, but without having to do a full sternotomy. So if you can make a little incision over the sternum and have this delivery tool that's able to place a lead through just this small incision between the ribs in this anterior space here, you can place a lead, attach it into the generator, and place this whole system somewhere in this sternal region. But this device could be implanted without fluoroscopy. It could even presumably be implanted in emergency situations, like in the emergency room. But again, this is not FDA approved. It's still, all of these are sort of the future technologies that we're looking at. Really, the future technologies are smaller with hopefully improved longevity and less complications. So in conclusion, again, pacemakers are used to treat slow heart rates, defibrillators are used to treat fast heart rates, and physiologic pacing being one of the really exciting new things, with either biventricular pacing for the patients who have heart failure or His bundle pacing for really anybody that needs a ventricular lead. It can be implanted about 85% of the time. There are about 15% of people who you try and do His bundle pacing and it doesn't work for whatever reason. And really, MRIs can be done safely for many people who have pacemakers and defibrillators. It's just a resource-intensive field. And then leadless devices, whether it's leadless pacemakers or subcutaneous ICDs, this really is the future technologies to me. And it's really, really an exciting time to be in my field because we're really at the cusp of really some big major changes. So thank you very much. I really appreciate you being here with me today. And if there's any questions that anybody has, you can either submit those, or I'm happy to answer any questions in the future. And here's my email address. So thank you very much.